we're going to go back to Chennai briefly for a short live case, I think. So Shiva, can you hear us? We see.
Yeah, can you see Srija? Srija was
okay, we're with you.
The operator. Srija, go ahead.
Good morning. This is a 29-year-old lady who was recently diagnosed to have a hypertensive ASD. We had done a CAT study 1 month ago, which had shown a pulmonary artery pressure of 80/34 with a mean of 48 millimeters of mercury, against an aortic pressure of 106/70 with a mean of 80 millimeters of mercury. She had a resting left to right shunt of 2.5:1 with a PVRI values which are moderately elevated to 6.6 Wood units and a low PVR-SVR ratio of 0.19. On oxygen, there was not much change in the PA pressures. However, the shunt increased to 3.3:1 with a reduction in the PVRI to 3.6, and the PVR-SVR ratio remained low. So in view of the resting left to right shunt with a moderate elevation of PVRI, we decided to close the ASD using a fenestrated device.
Shaq, is Dietmar around? Basically, we wanted to stress upon a large number of adult patients with atrial septal defect we do come across in clinical practice wherein the pulmonary artery pressures are significantly elevated, however continue to have a left to right shunt of more than 2:1. Now when we calculated the PVRI here, it was 6.8 Wood units, close to 7 Wood units, and so we were not happy to close it totally. So we decided that it will be a treat, partially close and continue to treat strategy. She was started on pulmonary vasodilator targeted therapy with bosentan and sildenafil, and we decided to put in a fenestrated device. Shaq, can you hear me?
Yeah, we can hear you and we see your device, yeah.
Okay. So the question is, in these grown-up patients, even though the shunt may be more, complete closure may be associated with persistence of pulmonary hypertension and may lead to syncopal episodes in future. And so we wanted to have a fenestrated device wherein the shunt will be stopped, and then we can continue on targeted vasodilator therapy. And actually Dr. Srija had already deployed the device. I will show you the echo images now. Can you show the echo big? Echo?
Okay. So what size device have you deployed and what size is the fenestration?
The ASD was measuring 26 to 27 millimeters, and the device that was used was 30 millimeter device. It's an Occlutech 30 millimeter device with a 6 millimeter fenestration. Up to 30, the fenestration that is made is 6, and in larger sizes they make a fenestration of 8 millimeters. And you can appreciate here the fenestration flowing left to right, and this is the 2D view of the fenestration, and this is the 3D en-face view, and we can appreciate the persistence of the color flows across the fenestration. We have data of a few patients where we have adopted this strategy compared to the previous Amplatzer devices where we used to make customized fenestrations using bipolar cautery and burning the fabric out. The Occlutech AFR has shown a reasonable patency. I'll show you a fluoroscopic picture of the same. Can you show fluoroscopy big? You can appreciate the fenestration on the fluoroscopy at around 11 o'clock from in relation to the cable.
Let's make the fluoro big.
Yeah, make the fluoro big. Was it a Cine or a fluoro store?
Cine.
Cine, okay. So
and we can see, yeah, we can see the fenestration there, yeah.
Yeah, and what you are seeing adjacent is the pulmonary artery pressure and central aortic pressure simultaneous. Show the hemodynamics live big. Hemodynamics. There is a definite left-right shunt that we are appreciating on the echocardiography. However, the pulmonary artery pressure is quite substantial. Take away my picture and show the echo big. Echo, hemodynamics together. Yeah. So as I speak to you, there is a continuous left-right shunt, but the pulmonary artery pressure should switch over to hemodynamics. Hemodynamics. Yeah, make the hemodynamics big. You still find that the pulmonary artery pressure is around 83.
It's going to be a good sign, isn't it?
Yes, Dietmar?
And you don't expect the pulmonary artery pressure to drop so quickly anyway in this sort of situation, do you?
Correct, correct. Yeah. Actually, in some of the patients where we had put in an ASD device, in some of them where there is a very, very responsive vascular bed, we had appreciated that in some of them there is an immediate fall. Like what was originally 80s will come down to 50s or 45 systolic in patients who are having torrential left-right shunt. Whereas in this patient, in fact,
we've got 30 seconds with you.
Hello?
30 seconds, yeah, telling. 30 seconds more.
We've got 30 seconds with you.
Yeah, Shaq, that's over. Actually, what we wanted to show was this product, the Occlutech AFR, the Occlutech fenestrated ASD device, which will probably have a good role on patients who are either having a restrictive LV physiology or persistent pulmonary hypertension, where we are not interested to close the hole entirely. However, we want to have a partial closure.
Thank you very much. Very interesting case. Excellent.
Thank you, Shaq.